Hi everyone, my name is Rachel Moses and I'm a consultant respiratory physiotherapist by background, and I'm currently in a Chief Allied Health Professional role. And I'm delighted today to be joined by three amazing physios as part of the Acute ICU Physiotherapy podcast part 2. So we've heard from David McWilliams, who gave us a one-to-one account of what he's been experiencing, and now we've got together three amazing clinicians from very different centres who are going to share their experiences about ICU physiotherapy and the role that they've had in their unit. As per the other podcast, we're not saying this is the only way to do things or the right way to do things. This is just lived experiences, and we're so grateful for people for sharing them because they open themselves up to critique and criticism. So if I just introduce the panel, to my top left is Laura, who is ICU Physio Team Lead at Guy's and St Thomas's Hospital in London, and she's also the Public Relation Officer for the ACPRC. In the bottom left is Katie, who is Team Lead Cardiothoracics and Critical Care Physiotherapist at the Royal Brompton and Harefield Trust, also in London. And then to my bottom right, there's Zoe, who is Clinical Lead for her General Intensive Care Unit at the University Hospitals of Southampton. So thanks everyone. So I just want to start by asking each and every one of you about if you can think back to a couple of months ago when we first knew that COVID was going to hit our intensive care units and it was going to hit hard, and we started to think about modelling our intensive care units. So Zoe, if I can come to you first, and can you explain a little bit about how your particular intensive care unit remodelled themselves to help meet the potential increase in demand?
So to begin with, we were in meetings where we were talking about ventilating possibly 300 patients, and at the moment we have about 50 intensive care beds across the trust. So it was all pretty scary to start with. So our surge plan was to move out of the general intensive care unit bit by bit and into the paediatric intensive care unit. And then beyond there, we'd be looking at theatre space and things like that. But in the end, we didn't have to use that. But within the paediatric intensive care unit and general intensive care unit, we did use double bed spacing, which I think has been quite commonly used. And then all of our normal general intensive care patients were moved into the cardiothoracic intensive care unit.
Thanks, Zoe. And Katie, if I can move to you next, you kind of completely remodelled the existing critical care workforce that existed at the Royal Brompton, and you're slightly unique in that there's no kind of A&E entrance, isn't it? So all your patients were either locality patients or came from other centres across northwest London.
Yeah, exactly. So we currently have an 18-bedded cardiothoracic critical care, as well as our severe respiratory failure ECMO retrieval service. So as part of remodelling and increasing our bed capacity, we made our recovery into intensive care unit, so we gained an additional 10 beds there, and also our paediatric colleagues are amazing and helped to transform the paediatric intensive care into an adult intensive care, as well as our kind of post-surgical high dependency unit was also made into an intensive care unit. So I think our capacity ended up going from 18 to about 80 beds, and obviously supporting staff across all areas. So having mixtures of intensive care nurses everywhere. Yeah, so it's pretty impressive what they achieved in quite a short space of time.
Absolutely. And moving on to you, Laura. So Laura, you work in probably one of the biggest intensive care unit capacity trusts in England. And so how did you guys manage to increase your capacity?
I think kind of similar to the others, really. So the aim was 350 beds in total. I think we did top out at about 190 patients at our peak, and then kind of stabilised around 120. So repurposed PICU, so they moved to their new PICU, going out into overnight intensive recovery, and then also the double pendenting or double bed spacing that other centres have done, including our ECMOs. So yeah.
So I think it's one thing to increase capacity, isn't it? It's one thing to have an extra bed space, and if we could acquire the equipment that's needed for an intensive care unit bed, but the workforce is something else. And there's been a lot of press, if you like, around the nurse and staff critical care shortage, which is absolutely fundamental for an intensive care unit. But it's also about the therapy workforce as well, and the physiotherapy workforce. So how do we even start to look at the workforce that's available and how we train people, you know, within days, we're talking days, not weeks, to be able to come into the intensive care unit? So maybe Zoe, if I start with you, how did you identify, how did you train and skill staff to be able to support your existing ICU physio service?
Well, we're quite lucky that we've got about 80 people on our on-call rota anyway, so we didn't in the end have to, we did have plans to, we didn't in the end have to train anybody else to come up. Obviously people were redeployed into other support roles, but in terms of coming into the intensive care unit, we only used the respiratory on-call staff. Having said that, intensive care is obviously a very different place at the moment, so there was a lot of training to be done, and we very much concentrated on our staff becoming COVID competent rather than respiratory competent. So we would just go through 5 tricks at the bedside, using the ventilators, just doing these 5 things that we could do, talking a lot about the things that we couldn't do, and trying to reassure people about what it was like once you went in, and just trying to really reassure people around the anxieties about putting PPE on and going in, because actually once you were in, everybody was happy. It was just getting through the doors, which was the real anxiety provoking bit.
Mm-hmm. Mm-hmm. So moving to you, Laura, again, I know there's a lot of physios that work in your trust. So was it easy? Was it difficult? Did you have strategies that you implemented? How did you do it?
I think we were quite lucky because we knew early on that what the ask was going to be and how many more beds we were going to get. So we could kind of plan right from the beginning. But one of the things that we found quite useful was a bit of a skills spreadsheet, because we couldn't just pull everyone who was on call. We actually needed more than that. So just looking at what skills people had, how long they'd already been on ICU, had they been on ICU for 6 months a year ago versus 3 months 10 years ago, and then trying to pull from those people and then put the training in place. And we also leveled our training, so there was 2 different levels depending on what people's background was as to how how experienced you are as to what kind of things you need to learn.
Yeah, so from some of the other podcasts, they've talked about like self-competency checklist, self-competency assessment form. So if you're not on the on-call rota is standard. That's easy for us as managers, isn't it? To say if you're on an on-call rota, we're pretty sure that you could be working in a COVID intensive care unit. It's the people who are maybe 3 months, 6 months, a year down the line, who have come off the rotas, who actually still feel them skills might be fresh. And in the managers podcast, we talked about how we refresh people, and we don't like to use the word upskilling because often therapists, nurses, medics have different skills. They're just not in intensive care. So coming to you, Katie, like you work in essentially a heart and lung hospital. So yeah. Did you have the similar strategies to the other 2, or did you do something slightly differently?
Yeah, so as you said, all the physios in our trust do on-call routine as part of kind of normal working pattern. So, but I would say there definitely was still that same element of anxiety. So obviously not all of them would be specialised in critical care. So there definitely was an element of, I guess, the unknown and being put in situations that was out of their comfort zone and they weren't necessarily familiar with. So we did kind of similar training programs in terms of we made, like Zoe touched on, COVID specific competencies, and we got our staff to score themselves in terms of how confident they felt in managing those situations. And then I think we're quite fortunate that we did have like quite a good skill mix of people on site and managed to do a lot of buddying up systems. So depending on how you scored yourself, you were buddied with somebody who was very happy versus somebody who's not very happy, and they almost act as a bit of a mentor. So you kind of went onto the unit with them and talked through how you might treat the patient and how you might assess the patient. But we also talked a lot about when not to treat the patient, and I think there was this element of anxiety of, oh my god, I've been called, I need to go and do lots, but actually we were seeing initially a lot of inappropriate calls, and there was a sense of I must treat. So we did a lot of work around recognizing that physio is not always going to fix all of these problems that we were encountering.
No, I think that's so important. So when we think back to 2 months ago, and we've had this chat offline a little bit, when I helped to write this international physio document thing, and we're like, these patients don't have secretions, they're probably not going to need physio and intensive care, and how wrong were we? Because actually these patients do, in the UK anyway, the phenotype of patient we're seeing in the UK is that they do have secretion problems. And if they don't have them from day one, they definitely are starting to have them day 2, day 3, day 4. And this is where we have a flexible workforce, don't we, to meet the needs of the patients. And like you touched on, Zoe, as soon as we realised actually physios were needed in the very acute phase, when they're sedated, paralysed, for whatever reason, it was really important that we were there and we had a workforce that knew how to manage COVID-specific patients. So you've touched a little bit, Kate, as well, in terms of how we've managed that. But I just want to come back to you, Zoe, and talk about some of the main challenges or the main things we were seeing in COVID patients, and also like how we assess these patients without having certain skills in our toolbox, like auscultation, and how we manage that.
Well, yeah, it's really hard, isn't it? Because you're getting called all the time from the nurses who are stuck in an isolation room, and they count on us for support most days. We're all part of a big team, and their patients desaturating, and the assumption is that it's a sputum plug. So trying to decipher through the window whether it's a VQ mismatch or whether it's a sputum plug was pretty tricky. I mean, it's going to be so weird going back to normal times and using a stethoscope again, because we've got really good with our hands again. We've gone back to basics. And in fact, one of the most important people that we had redeployed to us was a peds physio. And she was just treating them all like big kids. She was getting her hands on and she was doing loads of manual techniques, and we learned so much from her. And I think in previous times, we've relied probably too heavily on, manual insufflation, exsufflation and birding and kit and all sorts of diagnostics. And that all went out the window really quickly. So we had to adapt very quickly to really just going back to basics.
Mm-hmm, absolutely. And Laura, if I can bring you in here. So in my experience, and certainly what we talked about with David and some of the other podcasts, is these patients, when they do have a secretion load, which not every patient will have, we needed to use a lot of saline. We needed to use manual techniques, manually assisted cough, expiratory techniques, across a wide number of patients actually, and not just one treatment a day, shorter treatments. And that's why we've had to remodel the workforce in terms of not being 9 till 5. And so can you just give us your experience of that type of patient, COVID patient?
Yeah, I think it was almost a bit of a surprise when it all started, because we all thought they weren't going to be plugging off and phlegmy, and there's lots of talk about not using nebulizers, not using water humidification. And then obviously as time went on, we found that a lot of them do seem to be productive, and also that we were compounding the issues by not having nebs, and maybe some of our vents were just on dry circuits or HME exchanges. So a lot of manual techniques, a lot of saline sedation, sometimes VHI as well, though we did have a lot of issues with people who were already reaching peak pressures, really poor compliance, so that limited that quite a lot. And just like positioning and things like that, and manual assisted cough. I mean, we have a bit of an issue with our ECMO patients because we can't do really abdominal manual assisted coughs, that limited them. But I think a lot of physical work and just making sure that it's sweaty in that PPE. And also it being a two-man job, because a lot of our nursing staff were surge nurses who maybe weren't as familiar with physio techniques, the way that we instill saline, or how long we suction for. So just sometimes it was double physio treatments and trying to, I suppose, spread the workload or spread your arm load.
No, absolutely. And I think the bigger centres with bigger numbers aren't better by any means. That's not what I'm saying. But certainly this common thread of experience as respiratory physios that we're seeing is exactly what you've just said there. So Laura, if I can bring you in, and then maybe if anyone has any comments about this, about the use of water humidification. So again, if I think back to 2 months ago, these patients weren't getting trachees, we weren't using water humidification, none of them were getting nebulizers. But yeah, our practice has changed. So in terms of what humidification strategies do you use in your trust, Katie?
So initially, when this all started, we, following the guidelines about, dry circuits, it wasn't, there was we were seeing a lot of patients having really, really sticky secretions and very, very difficult to clear and needing input. And then we changed towards like the heated humidification circuits, and people were feeling a lot more comfortable about having how to have saline or other kind of nebulizers and mucolytics safely put into circuits, and using kind of one-way valves and spring-loaded nebulizer circuits to, I guess, prevent that breaking the seal. We certainly found that following changing from the dry circuits onto humidification or using kind of nebulizers a bit more freely, that we were clearing a lot easier, obviously, and in terms of like nurses being able to manage the secretions as well, it was a lot more, they were managing a lot more than what they were initially, especially, you know, the nurses who were experienced in managing those chests. We were finding that we were having to naturally support the nurses that had been redeployed into intensive care a lot more with the managing of these, but it was yeah, they were the main strategies.
Great. And Zoe, is that similar to your experience, or?
Well, no, I don't really know why. So I keep seeing on Twitter all of the bunged up ET tubes, but we've just not had that. So I think we've had 80 people through critical care, and I think we've used a wet circuit on maybe 2. But other than that, they've been all right. And, you know, our mortality is fantastic. We've got like a 19% mortality. So I don't know I don't know if people are different in Southampton, but we just didn't have the same. I mean, you know, obviously we found early on, like the other 2, that we're going to need something. So we, you know, it wasn't completely dry. We were able to use, like Katie said, the spring-loaded nebs and that sort of thing. But yeah, we just haven't really had anything, you know, anybody plugging off really.
And David in Birmingham said exactly the same. He said they use HMEs as standard normally. They don't use wet circuits, and their incidence of tube blocking or secretions is exactly the same as yours. So what's in that? I mean, I don't know. There might be nothing in that. It might be, you know, presence of other respiratory conditions. It might, you know, it's who knows. It might be ventilators used. It could be ventilation strategies. They use mucolytics from the start, so they started carbamazepine on admission. There's so many lessons to be learned, isn't there, from each other, for sure. So, and Laura, do you have anything to add?
The carbamazepine one's quite interesting because we weren't doing that initially, but we started doing that a couple of weeks in, just everybody on carbamazepine and pre-extubation as well, whereas we'd normally go down neb route, really. So, yeah.
Yeah, so again, I think in terms of this being a respiratory physio podcast, these are the questions that respiratory physios are asking. You know, we're seeing these problems, how do other people treat it? And again, 4 centres there, 4 very different approaches. So in terms of, we've talked about things we can do and things that have been beneficial, and Katie, you touched on this a little bit about what should we not be doing or what can we not be doing. Now, initially we were never going to bag these patients, we were never going to use manual hyperinflation, but actually we found sometimes it is needed, and to do that we'll have to do it safely by clamping the EP tube using viral filters. And when we are using anaesthetic machines, obviously there is a standby mode and you can manually hyperinflate using an anaesthetic machine and bag. So Katie, obviously people are after advice, things that maybe don't work or that you wouldn't necessarily do. Have you got any thoughts and comments around that?
What we wouldn't necessarily do. I found initially when this kind of started, we were seeing patients being quite cardiovascularly unstable at times. So I was advising my team to kind of do your assessment and do your initial treatment in kind of the supine position or however the patient presented, and monitor how they were kind of responding to your interventions. We have had a few patients become kind of cardiovascularly unstable or kind of desaturating during treatment. Obviously there's a lot of emphasis on not breaking the circuit, so we haven't really had any situations where we've needed to bag people or do manual hyperinflation with people, and we kind of had those discussions with the medical team, because there was a few incidences where physios were being called, kind of one patient's got deproned and kind of they're kind of not tolerating the kind of the mechanics and the change of position and the ventilation very well, and physio were getting called into those situations. And we had patients who were on kind of 100% oxygen and PEEP 15, and just had those conversations with the consultants, and like, you know, where do we go from this? If something was to happen, how do we manage these? So initially we were very, very kind of reluctant to do any form of manual hyperinflation, but we were kind of doing maybe like your inspiratory holds, trying to increase their PEEP to kind of recruit them a bit more. Like Zoe touched on earlier about kind of not going straight to the bird or your prophysis, and trying to prevent kind of bringing those pieces of equipment onto the unit. So it's actually, it's raised some really, really interesting chats, and it's been really, I mean, I found it really beneficial working alongside the respiratory medicine colleagues and thinking about things with a different cap on, and thinking about how we can facilitate airway clearance, and how to, I guess, support these patients. So yeah, I personally found it really useful working with other specialist respiratory physios outside of critical care, and thinking about how you might approach things differently. We're seeing a lot of dysfunctional breathers as well, kind of post-COVID, and trying to how to manage these alongside the rehab. So yeah.
No, absolutely. And Zoe, can I come down to you there?
Yeah, are we doing things that we don't do, or things that we do?
Yeah, things that maybe you've found that have been successful, but also things that you just think, nah, I just wouldn't go there, we don't need to do that. Anything different from what Katie has just said there?
So yeah, no, we haven't broken any circuits either. Well, actually, I'll tell a lie. On Friday we did break one with a clamp, because, you know, they have a really long ET tube when they're proned, and the patient had been supine for a while, and the tube was just too long, so we cut the tube. But other than that, we haven't had to do any bagging or anything like that. I think it's been covered by Laura and Katie between them. But the 5 tricks that we did our teachings on were just the VHI with peak pressures allowing, inspiratory holds, manual techniques, manual assisted cough, and positioning, and that was pretty much all we had. And we've stuck to those. And to be fair, they've worked. So you know once you've been through the 5, there's nothing else you can add. And that made people feel, you know, a bit better about leaving the bedside. You know, if you've done all of those and you can't do anything else, then you can leave. So yeah, what else challenges wise? I think early rehab, I know this is more of a respiratory chat, but we did find that patients were doing much better than we expected them to do quite early on, and so we were like, oh my god, we're going to have to rehab these people, we can't leave them forever. So you know, proceeding with caution with everything that we'd heard about fatigue and desaturations, and that's absolutely what you see. And as a massive early rehab advocate, we have had to slow right down, and really take it much easier, because the patients exhaust quickly. I had my own bad experience where a patient was extubated in the morning, because of a chat that I had with the patient. He was on NIV, and I took him off the NIV for a chat, and he was really good, and his stats were really good. So we sat on the edge of the bed, and he was really good, and then he really wasn't good quite quickly. And we obviously got him back to bed and put his NIV back on. And unfortunately, he was then re-intubated later on that day, and he went on to do really well. He's at home now, but I learned very quickly that you should always do, if you're going to do some rehab, you need to do it on the highest level of support that they're on. So I should have done his rehab with the NIV on, and that's what we've been doing moving forward.
No, I think that's a great learning point, and that's part of one of the main reasons why we're having this conversation right now online, is because we need to learn about this. And what we found is that these patients have very poor respiratory reserve. So even though physiologically they might look good at the time, they might be on low oxygen requirements, and they might be on even just high flow oxygen rather than a non-invasive device, whether it be CPAP or NIV, that as soon as we start doing things with these patients, they can decompensate very quickly. And these are young people with no respiratory comorbidities. Yeah. So the carryover effect of the ARDS of COVID lung is really significant. But when we get through that very post-acute period, actually they can do quite well with their breathlessness quite quickly, and fatigue's being a main limiting factor. But again, we have these 2 kind of phenotypes of patients, and there may be some correlation between that weaning phase, because everyone keeps asking about weaning and extubation. And I said it's way beyond a 45-minute podcast to talk about weaning strategies for these patients because they're so different. But you almost have the patients that are sedated and ventilated with a tube, with an AT tube, who you wake up and you extubate. Some of them have airway problems, some of them have voice problems, some of them have breathlessness, like you said, Katie. And then there's the other type of patients who are actually delayed or, significant weaning patients that need the trachees. So if we think about, if I come to you, Laura, in terms of your rehab strategies, so you have the patient, think about the patient who's been sedated, paralysed, proned, that actually they get to a point where they're on a decent oxygen level, a decent pressure support, and they extubate. What kind of rehab strategies do you find really beneficial for those patients?
I guess what we always have done traditionally is they pretty much sit on the edge of the bed immediately post extubation. But I have to say, with the COVIDs, we have taken things a lot slower, a lot more in bed assessments, trying to figure out what is their response. Are they going to decompensate? Can we push them further? Should we not push them further? And maybe even delaying it by a day before we're kind of physically getting them out of bed. There's been some debate about whether we should or shouldn't increase our oxygen before we even start. It's a bit of a tricky one to answer. I have to say I go more with my gut at the time, but and also maybe depending on what they're on. We've had, when we're talking about things that we should and shouldn't do, originally we weren't allowed to use high flow, just from an oxygen flow perspective across the trust. So it's also then weighing up where you can go in terms of your oxygen delivery and how you're going to support them, and from a breathlessness perspective.
Yeah, pre-oxygenation is a funny thing because before proning and before, when patients are intubated, it can just be a bit of a rescue or pre-rescue technique, if you like. But actually, when patients are off mechanical ventilation and vasoventilation, the physiology doesn't really make sense, does it? You give someone a blast of oxygen, well, you then lose that indicative marker if you know that someone's started to physiologically become compromised before they are. So we all know that by the time someone's got an increased respiratory rate or an increased work of breathing, they're already in trouble. Whereas if you monitor their saturations and you slowly see them, you think, actually, let's just stop and let's just take hold. And that's kind of like my whole thing about who treats these patients in that very post-acute phase, because I love the idea, like you said, Kate, well, I think all three of you have said it about the buddy system, having someone that's really skilled and someone who's maybe not as confident, because then that skilled person just has a gut feeling, don't they? Actually, this isn't quite right, this patient's not quite ready, they're telling us they want to do things. And I don't know what your experience, Katie, is, but we talked about this in the psychology session in particular, is these patients, once the tube's out and once their delirium's kind of becoming more controlled, they just want to get home. They don't want to stay in hospital. They will hide their symptoms. And we were seeing muscle fatigue and muscle weakness quite significant in this patient population. And therefore, they may not tell us some of the symptoms that they have. I don't know if you've found that in that acute phase.
Yeah, I mean, I think we're seeing a massive variety. So like you said, patients who kind of get extubated and they do quite well quite quickly, versus like the long-term kind of trachea weans who are kind of progressing quite slowly. So in terms of discharge, we were chatting earlier on today about some of our patients and the onward support that they're getting in the community, and almost having some elements of anxiety that we're sending them home as much support as we could offer them, but are they really getting as much input as they really need for, like you said, all the symptoms that they have? So like their post-viral fatigue, and are they, are we managing them onwards as best as we can? So yeah, but they are obviously desperate to get out of there, aren't they?
Completely. So I'm just going to start summarising some of the things that you guys have taught me today, because I've certainly learned a couple of bits there. So in terms of, if we were to ever, heaven forbid, be in this situation again in the future, or what we are all four of us, and probably the rest of the kind of leadership infrastructure of respiratory physiotherapy is mindful of, is that we might have another surge. This might not be the end, and it would be foolish of us to think actually we're going to have this workforce that's kind of been arrived to us from MSK and orthopedics and wherever else, and we've created a refreshed skills training, etc. So we're very mindful of that before they go. Actually, let's just recap here what you know, how we've achieved this, the added benefits, how we do things differently, what we've learned. So the self-assessment checklist type of forms, you know, what do you feel confident? What do you need a bit of help with? What would you feel comfortable doing? Would you want to work in the intensive care unit? We talked on one of the other podcasts how all of these physios and other professionals actually, or other colleagues in medicine, nurse and support staff, they found these people coming to them saying, what can we do? We want to help you. And we just need to know a little bit about this. COVID competencies, I love that, Zoe, the COVID competency specific stuff. And I'm sure if you three have things you wouldn't mind sharing, we can add it on to the bottom of this podcast. The buddy up system, so one highly skilled or really skilled individual with someone who's maybe lacking a bit of confidence, and over time they'll get more confidence or get more skills. PPE, donning, doffing, breaks in the PPE, practice run, simulation as best you can, time allowing in the PPE because it is a challenging environment. Using your hands, so use our hands, feel the patient. Use manual techniques, but also understand the ventilator and how to use the ventilator. So that might include hyperinflation, inspiratory holds, understand anaesthetic machines that might be used in your organisation, and understand the value of good positioning. So I don't know what you guys have found as well, but when someone's in a lateral position, you'll go along and they've got one pillow under. Now when people are in a lateral position, they're really in a lateral position, and that's because with the kind of skills training we've been doing with not just therapists but with nursing staff and healthcare assistants as well, and know the five. So Zoe, I think you need to paint in that know your five and write it on a piece of paper for us, and we'll get that at the bottom as well. So I want, with all that in mind and everything I've just summarised, I want to come to each of you individually and either bring some things out or comment on things about how you are preparing for this next phase, this grey area phase, and then potentially if this was to happen again, how you would manage it, things you do the same, things you do a bit differently. Laura, if I come to you first, please.
Yeah, so in terms of what we're doing to prepare, so we've kind of been told that we need to be able to increase our staff by 30% within a 48-hour period. So just trying to figure out who's going to be available, who's going to be redeployed, or de-deployed, or whatever the correct term is. So trying to figure that out. Our head of physio has actually just sent out a survey monkey asking staff about kind of their working pattern during COVID, what they liked about it, what they didn't like about it, whether they would want to stay in the area that they've been redeployed to, whether like what things have changed. So I think there'll be some really good info coming out of that survey that will then help us plan for if/when this does happen again. Things, if it does happen again, I think we went into zones at one point so that we were individual teams in each zone because our geographical area is quite big, and that did work quite well. So you had a really good skill mix. So I definitely look at doing that again. And then communication during the whole thing is just so key. And I know that sounds a bit twee, but when you're communicating to that many members of staff and people who are not normally in those areas, and the MDT, and even when you're wearing PPE, just trying to come up with the best strategies of disseminating information quickly, but key messages, because I think a lot of it gets lost and there's a lot of toing and froing and maybe a lot of hearsay, a lot of rumours, and if you can kind of fight that at the start, then that really helps.
Fabulous, love that summary. Katie, moving over to you.
Yeah, just to echo kind of what Laura's just said about communication, we were finding the pace of change quite overwhelming, and you'd come on and you do 4 days and have 3 days off, and you come back and it's like, oh, it's all different, and staff were almost finding that they needed to almost like keep in touch on their days off rather than fully switch off and take that time to unwind. So we set up an old WhatsApp group, and it was like the staff in that day were in it, and then once you were off site you had to leave the group. And we also in our main kind of MDT room had a communications board, or like a minutes board, and any kind of big decisions or any changes that were decided on that day, they were written up on the board. So when you came in on your next shift, you could say, oh, the bleep is now this, or we've now doing this in that area. So that tried to help alleviate some of those, I guess, stresses of trying to keep up with the constant changes. We're trying to start to revert back slightly to a bit of normality, whatever normality is going to look like after this. And we've set up a bit of a rota so that kind of physios from other areas will come in, spend 2 weeks with the COVID team, and then go back to their other areas, and like just to give them a sense of stability, but also like just continuous and patient consistency as well. And I think it's just really important to recognise how amazing everybody's been and how rapidly everybody's adapted to the changes that we've asked of them, and what it's quite a scary and unknown time. Everyone's just been wonderful and just celebrating their successes really, and giving them time to have those debriefs. So I think that's really important.
Fabulous. And Zoe?
So something we did well, which was that we did a debrief every single day without fail, for an hour at the end of the day, and it was supposed to be set up for staff wellbeing, but in the end we did it as a what the hell is going on with these patients, learning from what went well, what didn't go well, what on earth do we do with them. But in doing that, it sort of did help the staff wellbeing, so that was really good, and that's been really good, and I would definitely make time for that going forward if it happened again. Echoing what the other two said, I've certainly reflected on my own leadership. Not everybody needs to know everything every time. So when we've heard a lot of changes, literally, I'm sure you've all had the same, literally minute by minute, hour by hour. And in trying to keep people in a loop, I would tell everybody everything. And not everyone does well with that. So I think trying to maybe filter throughout the day, and then just at that one debrief session, just as Katie said, just sort of listing the key points rather than just everything all the time, because it just stresses people out. But exactly what Katie said, I mean, I would love to do some sort of report on how incredible it has been. I mean, we were talking about it on Friday, how peds physios are looking after adult patients, how cardiac physios are looking after polytrauma patients, you know, and there's been no moaning. Everyone's just got on with it and just been absolutely brilliant.
No, I completely agree. And the feeling nationally of how everyone's approached this, you know, within the NHS and certainly within our own profession is just incredible. And natural leaders are emerging, and they have permission to lead and learn. And we are very good, I think, as a profession, especially within respiratory physio, I have to say, about saying, actually, we didn't quite get that right, or next time we need to do this a little bit differently, or what did you do well? Because actually that, you know, we didn't get that bit right. And I think it's part of that open and honesty, isn't it, and reporting and sharing with each other. And I think, you know, if we do have a bit of time in the next few weeks, I think we need to do this a bit more. And I just want to say a massive thank you to you three for being inspirational leaders that you are. It's been great having you talk, and we're really grateful, and I'm sure so many people have got so much out of this. So thank you so much, and keep being brilliant.
Thank you.
Thank you.
Thanks everyone.